or I have questions for them. I need more information, things like that. And then payer is probably the least in terms of number of direct transactions.
Okay, got it. It's all clarified now for me. Cool. Great. So another kind of thing we hear, so we've started with hub, we combine it with the specialty distribution, and then we also have the players out there that are the hub, specialty distribution, and the GPO. So how does a payer view the GPO? We know the manufacturer, or we've heard the GPO is just kind of another layer on top. And then, so I'm just curious how a payer views GPOs, whether that's just another part of getting the drug, or it drives, or it really helps them reduce costs.
We see GPOs more as an organization it's a pharma supply chain, right? That's what GPO is. So as a payer, we don't necessarily see GPOs serving us directly with some money, but we do know that GPOs actually work together and they negotiate strongly with pharma and reduce the cost of their drugs. So we appreciate it, but we don't have any contracts with GPOs directly as payers.
Okay, got it. That's what I was just looking for, basically your direct interactions, but okay, that's helpful. And then the last part.
There are GPOs out there. They are pretty large, and they oversee, like Premier. Premier is a large GPO. They have contract with nearly 60% of all the hospitals across the nation. These are also the same hospitals that we as a payers are working for them as well. So GPO may have some program with these hospitals to help them save money, reduce infections, some data analytics services, things like that. They are well aligned with what we're trying to do. Like for example, hospitals, in Medicare world gets dinged and their reimbursement is lower if patient is readmitted within X many hours or days of discharge. And GPOs may have program to help these hospitals make sure that patients are healthy and they go out and their care coordination is done really nicely. And, GPOs charge some money to the hospitals for that services. And we as a payers, we also want to do the same. We want those patients to be treated, discharged, and get out safely as fast as possible. So there may be some parallel activities, but it has nothing to do with the hub.
Okay, got it. That's a helpful way to think about it. Because that's interesting. Because you think you got all these alignments that you think would really be helpful to a payer, be helpful to a provider, but it still seems a little fragmented in between.
There is. There's definitely quite a bit of opportunity, in my opinion. And when I worked at Premier, I saw this as a great, because of my background. But I'll be honest with you, they had very few people. They had very few people they had a payer background to think about this kind of alignment together and put the pharmaceutical needs and this public health, population health management needs together. And it was really excitable because that is exactly what the CEOs of the health systems were looking for. Pharma would find values as well, and they needed, but there wasn't any big, division that worked on payer benefits. It was either pharma and supply chain and, vendor management and purchasing and distribution.
Okay, got it. So I think it'd be helpful to spend the last 10 minutes or so kind of talking about overall trends in drug pricing and drug volumes and risks to increasing drug prices and things like of that nature. So we hear a lot about rebates as part of payers getting paid off